Good morning, everybody. Welcome to our webinar on Kawasaki disease. I'm Jane Newberger, a long-standing member of the Kawasaki team here in the Department of Cardiology. And we have three additional members of the team who will introduce themselves. Kevin Friedman, why don't you start?
Sure. Thanks, Jane. I'm Kevin Friedman. I'm a pediatric cardiologist here at Boston Children's Hospital who specializes in cardiac imaging, and as well, I'm a member of the Kawasaki disease team.
Dr. Quinones.
Hi there, Luis Quinones. I'm one of the cardiac surgeons here at Boston Children's Hospital. My area of interest is coronary arteries, and therefore I overlap a lot with the Kawasaki team.
And then Annette Baker.
Hi, I'm Annette Baker. I'm one of the nurse practitioners on the Kawasaki team. I've been kind of here since 1989, so we've all worked together for a long time. Welcome.
So we're going to go through some basic questions and then have time for questions and answers. So if you have questions, please put them in the chat and we will answer them toward the end of this webinar. I'm going to begin by asking Dr. Friedman, what is Kawasaki disease and how common is it?
That's a great question. So Kawasaki disease is an inflammatory disease. We still, after many years of looking for the exact cause, don't know the exact cause. And that's not for lack of research. People are really trying. But it is what we think causes it is that there's a variety of potential triggers. It could be viruses or other things in the environment that trigger an immune response in the body, and that immune response causes a lot of inflammation. And that inflammation can affect various parts of the heart and cause certain clinical manifestations, and importantly, can affect the heart. And we're going to talk a lot more about that over time. In terms of how frequent it is, it's mostly in young kids, so mostly children under 5 to 8 years of age. In that age group, under 5 years of age, there's about 5,000 cases in the US per year. And that means about 10 to 20 kids out of every 100,000 kids in that age group under 5 in the US experience KD.
And Kevin, how do we treat Kawasaki disease?
Yeah.
Are
So
there
the most,
go ahead.
So the most important thing is to recognize it. So, and that's usually the job of pediatricians and emergency rooms. And so once we recognize the signs and symptoms, which we can talk about later, the treatment is usually admission to the hospital, diagnosis, ensuring that there's no cardiac involvement by doing echocardiograms, and then treatment with intravenous immunoglobulin. That's an IV medicine. That's a very strong anti-inflammatory, and it helps children feel better and it gets rid of their fever, and it protects their heart. It makes the chance of a heart problem much, much lower, like 5 times lower. And so that medicine is very effective. There are other anti-inflammatory medicines we can use in certain cases, but that's the primary medicine we use, as well as aspirin to help with inflammation.
So how do you decide whether somebody needs right up front more medicine than just IVIG? And when does somebody get IVIG and then require a second medicine? How do you make that decision?
Yeah, so for us, we know that IVIG is the best medicine for Kawasaki disease. Dr. Newberger did one of the original trials, and it showed that without IVIG, about 25% of children have real significant heart problems with the coronary arteries, and with it, less than 5%. So it's really a very effective medicine. But we've learned, and we've tried to make that 5% even lower. And what we found is that there are certain children, especially very young children, less than 6 months of age, those with very, very high inflammatory markers, or who are very, very sick with like low blood pressures. Or the last one is those who have coronary artery problems coronary artery changes when they present. Those children we give extra medicine to, extra inflammatory medicines that prevent inflammation or reduce inflammation. And the goal is to try to help the coronaries get better. And so those children get it. And then the second category of children who get it is children who don't respond to IVIG. So most kids, just with IVIG, the fever goes away. It's about 85% of the time, but about 15% of the time, children have another fever after the treatment with IVIG. And for those kids, we give more medicine for anti-inflammatory medicines.
Thank you. Annette, you've just heard Dr. Friedman speak a lot about coronary arteries. So how does Kawasaki disease actually affect the coronary arteries?
That's a big question, but essentially, at some point in the initial phases of the illness, the inflammation affects the wall of the vessel, weakening the wall. And then as blood pressure and blood flows through those weakened vessels, they can expand in size and ultimately can cause an aneurysm or a bubble or an enlarged part of the vessel. And that process takes place over we think about the first month or two.
Right. And so often we see things early. Some children get better even in the first weeks, but a subset can go on and continue to expand even up to 6 weeks. And Kevin, we focus a lot on the heart, but can you ever have aneurysms in other arteries?
You can. So yeah, the inflammation that does affect the coronary arteries affects a whole bunch of parts of the body and shows up in a whole bunch of ways. Those include the classic symptoms of Kawasaki disease, but also can affect other, usually medium-sized arteries. It's much rarer than coronary artery problems, but other aneurysms can occur in things like the arteries to the arms or the legs. And often we can detect those by examination. And in some cases, we look for those even with CT scans and things like that. The important thing to know, though, is those don't really happen unless you have very large coronary aneurysms. So first, they're very rare. And second, we only really have a suspicion for those if you have very large coronary aneurysms because they don't occur. They only occur when you have coronary aneurysms that are large.
Can you talk, Dr. Friedman, a little bit about the size of coronary arteries? You're touching on this now, and when it becomes more serious or is less serious?
Yeah. So fortunately, most kids with Kawasaki disease do great, the vast majority. And the vast majority actually either have no coronary changes, that's about 75 or 80% of kids, or have very mild ones that get better. But among those children who have coronary artery changes, meaning their coronary arteries are enlarged in the first part of the illness, we know that what determines the likelihood of them getting better, the coronaries, is how big they are. It's directly related and is by far the strongest predictor of that. So children who have mild coronary artery changes almost always get better, virtually always. Patients who have very large coronaries, very, very big ones, it's much less likely. And so that's important in a couple ways. It helps us know that when we see patients who come in early on with coronary artery changes, we want to be very aggressive with our treatment because we want to prevent them from getting bigger because we know that's what's most likely to help them in the long run. And second, it helps us know that those children who unfortunately already have very large aneurysms, those are the ones we need to focus our treatments on and our very intensive surveillance to make sure they're not having complications from those aneurysms like blood clots or narrowing. So those are the important parts of it. But
that is a perfect segue to my question to Annette, which as our coordinator and are the linchpin of our team, how do we follow patients after they're discharged? And how often do kids come back? What kinds of tests do we do? And how do we decide on what tests we do?
Like Kevin said, it's all driven by the involvement of the coronary. So for a basic, straightforward patient with Kawasaki disease whose initial echo is normal, who responds well to IVIG, we typically, they go home on a low dose of aspirin and we see them in about a week for another echo. And that echo is very important because we want to make sure there's no change from the initial echo to that one. And then if everything looks good there, and the inflammation is subsiding, we see them again in about 4 to 6 weeks. And at that point, for the vast majority of children, if the coronaries have always been normal, we don't need to see them long term, and we expect them to do very, very well. That changes if you come in with coronary enlargement, or if you don't respond to treatment, you continue to have fever, or if your coronaries get bigger. In those scenarios, you stay in the hospital, getting additional adjunctive treatment, like Dr. Friedman said, and then we echo much more frequently every few days while you're in the hospital. And once the coronary stabilize, you go home, but we still would monitor much more closely, at least kind of weekly until you're better. And then we lengthen things out.
So that gets to the point that we tailor how each child is followed based
Mhm.
on their own personal kind of profile of how big those coronaries are, whether they're continuing to enlarge, in which case we follow extremely closely, or whether they have kind of reached a steady point where they're no longer getting any bigger, and then we expect that healing process to begin. Um, so, which brings me to a question to Dr. Friedman. Um, how likely are coronary aneurysms to recover? How does that process work? How do they, what happens at a kind of a
Yeah,
molecular level to the cells? How often do they go back to normal?
yeah.
What are the predictors?
So the biggest thing is how big they are to begin with. So the ones who are very small, 90 to 100% of them will get better. And if the ones that are very large, it's maybe 50-50 or less will actually improve. So, but overall, 75 or 80% of kids who have aneurysms, the coronaries will return to normal size. And it can happen in a couple of different ways. The best way is just that the coronary artery wall remodels. It just kind of heals itself in some ways. But it can also happen where the coronary artery wall gets thicker or blood clot develops, and that's one of the things we have to watch for. That's especially a concern when there's very large coronary artery aneurysms. Those aneurysms are the kind that can get smaller, which is usually thought of as a good thing, but sometimes it can be in a way that can lead to long-term problems. So that's why children who have, especially those with moderate or large aneurysms, we do a lot of testing even as the coronaries look better because we want to make sure they're getting better in a healthy way, not in a potentially dangerous way.
Dr. Friedman, you mentioned clots, and so I'm going to pass the baton to Annette, who manages many of our patients who are on medicines to prevent clots. Annette, what kinds of medicines do we use to prevent clots, and how do we monitor that, and how does it vary over time?
So specifically, that's kind of geared to our patients with aneurysms. So it's all incremental. If you have small aneurysms, we keep you on a small dose of aspirin. And if you have medium-sized aneurysms, we may add an additional anti-clotting medicine and antiplatelet medicine. But the people with large or giant aneurysms needs a combination of medicines that are both anticoagulant and antiplatelet. And so we use low-dose aspirin on all of those children. And in addition, we use typically in the initial phases, Lovenox, which is an injectable heparin, which has been used for many decades. And that's given twice a day. And then as the risk of clotting decreases later in the illness, we switch that to an oral medicine. And currently, there are a lot of new oral medicines on the market. Here at Boston Children's, we've been using apixaban, which is Eliquis, and we use that in combination with aspirin. Occasionally, if you have a child who has very, very large aneurysms with evidence of a clot already, we may use a third anti-clotting medicine as well. And these are monitored very closely. We do levels on the medicines to make sure that they're in a therapeutic range.
That's great. Brings me to a couple of questions. For Kevin, when talking about clots in coronary arteries is frightening. And when do you worry that a child with Kawasaki disease might be having a heart attack? And how are the signs and symptoms of that different in a young child compared to an older patient? How do you recognize them?
So I think the first thing that's important to say for most families and parents is the vast majority of kids with Kawasaki disease who don't have large aneurysms are not at risk for a heart attack. So there may be some testing, there may be some things that they need to do, but they're typically not at risk. But for our patients with large or giant aneurysms, there is a real risk of blood clots, which can lead to problems with blood flow to the heart, which is what a heart attack is. And older kids may present similar to adults, which is what we typically think of: chest pain, shoulder pain, shortness of breath, often with exertion and sometimes at rest. And so the older kids often will present that way, but younger kids, especially infants, really aren't going to be able to communicate that, and they present in different ways. And it's often with kind of extreme fussiness, sometimes nausea, vomiting, irritability, and GI symptoms. So that's a lot harder to recognize because they obviously don't speak. And if even in the toddlers who can, they're not going to be able to enunciate that. And so for families who have children with larger giant aneurysms, we're very cautious to give them those type of precautions that if they're seeing those type of symptoms, the safe thing to do is to come in and to be evaluated just to be sure.
That again is a good segue to Annette. How do we advise patients? A lot of parents want to know what they do in an emergency, when to call, how worried do they need to be to call, where should they go, what should they do? How do we advise them?
I mean, typically we try to teach anyone whose child has a larger giant aneurysm CPR so that they'll be able to do that if, God forbid, that is necessary. But if there's any concern, probably the best place for a child to be evaluated, if they have the symptoms that Dr. Friedman talked about, or if they have pallor or they just don't seem well and you're worried about them, is to take them to an emergency room where they'll typically be able to evaluate them, do an EKG, check an enzyme in the heart called troponin. It's always better to be safe than sorry. And we often will give an outline to a school nurse or to the caregivers. And you should always keep your child's information accessible so that people can respond if there is a problem.
Right. And we will always write notes to the school. We like parents to keep a copy of the letter that we write so that if they do, let's say you're on vacation, that if a question comes up, you can go to an emergency room and have all the information ready. All of these things are so rare. And so it's just a matter of being prepared. Knowing CPR, you'll probably use it on a coach in the football field rather than your own child. But it gives people a sense of security of knowing what they could do if they needed to. My next question is back to Dr. Friedman. How is the cause of a heart attack very different than in a Kawasaki patient than in somebody who is a 50-year-old man, let's say?
Yeah, so although it's the same idea that the cause of the heart attack is that the coronary arteries get blocked up and therefore don't supply adequate blood to the heart muscle, the actual cause within the coronary is very different. And children with Kawasaki disease, especially in the first part of the Kawasaki disease, the first several months, it's really the risk is a blood clot, an acute blood clot. So it kind of can go from no symptoms to significant symptoms. Whereas in older patients, it's usually more of a chronic progressive narrowing of the artery called stenosis. And that's usually more slowly progressive. And a lot of adults will have chest pain with exertion and things like that are warning signs. So in kids, it's a much more acute thing because it can be a blood clot, especially early on, and that can present quite differently and more acutely. Children who have Kawasaki's with large aneurysms do have a risk later on, years down the road, of narrowing of stenosis, but that's a different form of stenosis than adults get, and that's but they can get that as well later.
So how does, if you discover that a child or an adult is having a heart attack, what kind of interventions do you give? How does that vary with the age of the person, where you're being treated, how close you are to a cath team? What should parents know about that?
Yeah, so I think the first thing is recognition of the symptoms and getting prompt evaluation at a center that has expertise. And so, but first getting to your nearest center to get diagnosed and then transferred. So there are several different options depending on the severity, the age of the child, and what the team at the treating hospital can do. We can give medicines either through an IV or through a catheter that goes into the coronary itself that help to break down blood clots. Those are called thrombolytics. That's one option. We can give other types of blood thinners. We pretty much always do that. And then there's actually treatments that can be done to try to help mechanically remove or break down the clot in the cath lab. But those require expertise that are pretty rare. So it needs to be done at a center that really has done a lot of that. And so there's a couple of different options, but the biggest key point is to recognize it as the symptoms so that we can do testing to make the diagnosis of a heart attack and then proceed with the potential options.
So the diagnosis is making the diagnosis promptly is really key. And what that means as a parent is we don't mind, and no doctor minds, a false alarm. If you are worried in any way, it is so easy if you're at a medical center to send off a blood test, get an EKG, do an echo, and figure out whether there's any reason at all that you need to worry. Most of your worries will be false alarms. We know this from experience, but you should never feel like you don't want to bother somebody. It's just always better to check it out if you have any suspicions. A lot, uh, a lot depends on where you live, but if you have a child or you are an individual who is a little bit larger than a young baby, and you are at a hospital with cardiac catheterization lab facilities that are right there, and people who know how to do it, we sometimes also just open up the area in the coronary that is occluded with catheters. So we kind of make a passageway through the clot, and that is called mechanical restoration. Most of the time we wind up treating with medicines because people come in a little bit later or a child is too small, but both ways of doing things are used. And most important thing as a parent is to get to a medical center if you have any questions. My next question, I'm going to move on to Dr. Quinones to give us some surgical input. And again, we are highly focusing on those children with giant aneurysms here because we suspect many people on this webinar are parents or individuals affected by this. When do we recommend a bypass operation for a child or an adult? And what criteria do you use? And what are the technical limitations? How big does a child have to be in order to undergo surgery?
Yes, thank you, Jane. First of all, we want to have a significant narrowing that we see, and usually to make that diagnosis anatomically, we need a cardiac catheterization, not just a CT scan. Although the CT scan can give us hints, the cardiac catheterization is the test that you really want to know. And what is a significant narrowing? Anything above 50%, at least anatomically, gives you an idea. Yeah, but there's another way to assess it, and in the presence of a narrowing, if you're not sure how significant it is there a lack of blood flow to that part of the heart where the narrowing is beyond? And that's what we call that functional testing, and it can take various forms, such as a stress test, MRI with stress, or even a catheterization with some sort of stress. And there are others, nuclear studies and things. So you want the combination of a significant narrowing and evidence of lack of blood flow to that part of the heart to take a patient to the operating room to do a bypass.
I'm going to ask Dr. Friedman, how often, if a patient is developing narrowing, how often should the child be tested, and what kinds of ways do you think are best depending on the age of the child?
Yeah, it's a great question, and it's depends a little bit on what techniques are available, but I can tell you what we would do. So this is for patients with usually larger giant aneurysms that are at risk for those type of narrowings, and we do those at least every year or so, sometimes even more frequently if we're really suspicious. And the type of testing, like Dr. Quinones was mentioning, is the type of testing we want to do twofold. One is to get a very good look at the coronary artery, and that's usually with CT scan. And then equally important is a test to say, is the heart muscle getting good blood flow, like Dr. Coronary was mentioning? And that requires putting the heart under stress, which is usually exercise. If a child's over about 7 or 8, they can do exercise on a treadmill like an adult would do in an exercise stress test, and that would include an EKG, which will sometimes show changes like a traditional adult would do. And often we'll do things like look at the heart muscle, how it performs with an echo or an MRI while they're exercising, or even with a nuclear study, which is a way to look at ensuring there's good blood flow. So those are all ways we can do it in older kids. Younger kids are more of a challenge because under about 7, it's really hard to get a child to run on a treadmill hard enough to get their heart rate and blood pressure up. And in those cases, we often have to put them, we use anesthesia and then put them in an MRI machine where we can give medicines that do the same thing as exercise would, raise the heart rate and blood pressure, and evaluate that the heart muscle is still getting good blood flow with MRI. So a little bit depends on the age, but the simplest way is in the older kids to do a stress test and then look at the heart muscle during the stress test with some type of imaging.
Thank you. That's great. If somebody does need an operation, what is the youngest or needs something done? Dr. Quinones, what is the youngest age or smallest size in which you can do a bypass? And if child is very small, what other opportunities do we have?
So the age range of presentation is very broad, as you're alluding to, Jane. The youngest bypass operation we've done here that I've done is around 2 years of age. Okay, and you're dealing with very, very small vessels, and you have to be very careful going into these kinds of operations. Now, but that goes all the way up into adulthood. It's important to point out that it's technically it's the almost the same operation as what's done in adults for coronary artery bypass, for hardening of the arteries and coronary artery bypass. It's just that we're dealing with such small vessels. So the age range is quite broad. So
thank you. Thank you. Quick question for Dr. Friedman. For somebody who has giant or large aneurysms, what do you advise for sports? How do we advise parents and kids about the sports they can participate in and what limitations they might have?
Yeah, so we're generally very proactive about trying to have all of our patients maintain good physical fitness, good activity, and trying to really only limit them if it's a true danger to them. So we don't limit children, especially those with small, medium, or no aneurysms really at all. For patients with large or giant aneurysms, a lot of the limitation is really dictated by their anticoagulation. So contact sports, especially like football, and things that could cause head trauma are a little bit out of not a great idea for children on anticoagulants. But apart from that, as long as the families are aware of the concerning signs or symptoms, we don't restrict them from aerobic activity. So doing activities, including some sports that require running, is fine. It's really dictated often by the anticoagulation. And we know for all types of heart disease, congenital heart disease, Kawasaki disease, being physically active, being physically fit, and having good aerobic tolerance is going to help you in general. So we try not to, we discourage patients from being restricted, except for when it's a true issue with blood thinners, or certainly patients who are having symptoms of chest pain or things like that. Those are patients we would evaluate and restrict. But in an asymptomatic patient who's doing well, we try not to.
Thanks. Now, maybe one of the hardest questions for Annette. We know that our children graduate from childhood to adulthood, and that they transition from a pediatric cardiologist to an adult cardiologist. How do we ensure that there's a good transition, and how can you prepare children who have aneurysms and have to take medicines to care for themselves reliably?
I mean, transition is a difficult topic. We try to start early and teach the child themselves about their disease, about their medications, and really, most importantly, about the need for lifelong care. Some bigger centers, like here, we have a transition, kind of an adult person who deals with coronary arteries and patients who've had Kawasaki disease. And we usually do that around college age, after high school. But I think the education needs to start early, and it needs to include things like pregnancy on anticoagulants and signs and symptoms of heart problems so that the patient themselves understands it. Because often these children, when they present, are babies or toddlers, they're little, your relationship is with the child, but also very strongly with the parent. And so you need to kind of transition, start education early, and usually by young adulthood, make sure that they understand the need for lifelong care. In centers where they don't have a transition person who takes Kawasaki patients, you really need someone who's an expert in coronary disease and who has an understanding or willing to understand about the differences between Kawasaki disease and adult coronary disease. But yeah, transition is a huge topic and very, very important.
So this brings us to the end of our half-hour session. I just have a few comments. Just to summarize, that the most important thing about Kawasaki disease is recognition. And for a pediatrician, this is like a needle in a haystack because so many children have rash, red eyes, red lips, fever, and that high index of suspicion is the hardest part of the care of a child of KD. We are here, our team has 5 cardiologists, many rheumatologists, 2 nurse practitioners, one of whom is Annette Baker, and Dr. Quinones is our very expert coronary surgeon. There is somebody here to talk to you from the Kawasaki team 24/7, so every day of the year. And we also are very, very happy to do second opinions if you have questions. I'm going to open up the forum for any questions. And it looks like there is a question here. Hold on one second. Are you using a Pixaban with good results? We are indeed. Annette, do you want to answer that question?
Well, we are. There is a publication that we hope is in process and should be out there for the public soon. But basically, I would say about 7 years ago, maybe, Jane, we started using a Pixaban initially as part of a trial, and we've switched over really almost all of our patients to a Pixaban because we feel that it gives more consistent coverage. It's not as reactive to things like illness and antibiotics and so on. And it's a twice-a-day medicine, and we do have almost, I think, all of our giant aneurysm patients now on a combination of a Pixaban with an antiplatelet agent.
I would talk a little bit more about that also in terms of timing. So when somebody has acute Kawasaki disease, we usually begin with low molecular weight heparin. And we continue that for a variable amount of time. The highest risk of forming a clot is in that 15 to 45 day period. And then at the further out you go, the less likely clots are to happen. And they become relatively way less likely after about 2 years, although absolutely we see acute coronary syndromes even in adults many years later. But because apixaban and other direct oral anticoagulants are relatively new, we usually don't transition from Lovenox, which of course is an injection, to, at our institution, apixaban. We usually do it at around 3 months. There are exceptions to that. If a child or family is having tremendous difficulty with the injections and it just isn't feasible, then we may go to apixaban much earlier. But we do monitor levels, and that's different from what's done in adult use of apixaban, where everybody gets the same dose. It seems to be that children metabolize it a little faster, and so we do periodically just check levels. And I was just going to ask Dr. Friedman, do you have anything to add to that or any different way that you do things?
No, not really. I think it's a lot easier for families in general, apixaban is, than Coumadin. And Coumadin just has issues with diet and monitoring and the levels being too high and levels being too low. And as apixaban has grown in the adult world or medicine. Somebody asked in the chat about dabigatran. We just use apixaban here. That's what we're familiar with. There are several other very similar medicines, which are fine, probably fine. I don't think there's a specific, apixaban is just our choice, but there's several other that are in that category. So it's just easier. And if we don't have a ton of direct evidence, but what's increasingly becoming clear is it seems to be quite effective, meaning it prevents blood clots seemingly as well as Coumadin does, and probably has lower bleeding rates. So that the downside of all these blood thinners is that you can have bleeding events, and the apixaban bleeding events seem to be probably lower. So it seems to be both as effective and maybe even safer. So we're still working on more and more data, but so far it looks really promising.
Yeah.
And we are limited by the availability. There isn't a liquid form, and typically you have to use the commercially available milligram dosing, and you can cut the pills. So that's why we do weight-based dosing here, and then we monitor with levels.
I would just say that we haven't put anybody on Coumadin in a very long time with aneurysms. A second question is that some papers show that maybe dabigatran could not be an option. Oh, that is very related to what Dr. Friedman just said. We have not tested different direct oral anticoagulants, and as was just said, many others might be equally effective. Each center, which you'll find in the United States, uses one or another of these drugs that they're the most familiar with. There are 2 trials that have incorporated direct oral anticoagulants into their safety studies that have been published. One is the saxophone study, which used apixaban. The other is a study on edoxaban, which was also published in the Journal of the American College of Cardiology. There's no reason to suppose that others are different, and we're not making any commercial claims. We can't. We don't have any head-to-head comparisons of the different DOACs.
Jane, there's a couple questions there. Are you seeing them? Are cases of Kawasaki disease increasing or decreasing or holding steady over time?
I did not see that question. Cases of Kawasaki disease are not increasing in the United States. They do seem to be going up in Japan. So there's been a pretty steady rate in the US. What's very, very interesting is that the types of cases in Japan are different, and there are way more so-called incomplete cases of Kawasaki disease. So children are being treated with IVIG, even though they don't meet the classic sort of case definition with fever and 5 criteria, which are the red eyes, red lips, rash, node in the neck, big lymph node, and then peeling of the hands and feet. Some people only have 2 or 3 and are very inflamed, and they're considered to be incomplete Kawasaki disease and treated. I think if we look to the future, we desperately need a diagnostic test. Because there is none at the present time, and we may wind up treating more children than really are at risk just to be safe. But someday we hope that we have a blood test or a molecular test that at point of care where you first see a child will enable you to be much more exact than we are at present. Very nice note, I guess, to conclude this webinar on from Josh Dennison with a thank you. Thank you for your thank you. We are all passionate about Kawasaki disease and all here to make everybody as good as they can be. Looks like
there was another question that Jane, from a guest about what is the cause of Kawasaki disease?
The Nobel Prize question.
Yeah, which is a great question. And there's lots and lots of research going on about what the cause is. It'd be great if we could find it out, because then we could probably have a more specific diagnostic test, like Dr. Newberger was just saying. But what we know is there's a whole bunch of clues to what causes Kawasaki disease, but not an answer. So we know the rates are different around the world. There's different in different ethnicities. There are these periods of time where the incidence goes up, meaning there's more Kawasaki disease. So there's something that's circulating. So the best guess right now, and there's pretty strong evidence that there's a bunch of different potentially viruses or even other triggers that cause the body to have an immune response. And certain people seem to be more predisposed to that based on how their immune system works. And so that's not a very specific answer, but that seems to be what it is. And that's probably why it's so hard to find an answer, because it's not one specific thing. It's a trigger that then in certain people who are predisposed to that, their immune system kind of has this reaction and goes haywire and causes too much inflammation and affects these parts of the body. So I think that's the current best hypothesis, but still lots of work going on.
That was a great answer. It says, we were at the beach. Another question, we were at the beach, stagnant water or carpets that were cleaned? Very common question to us. Do you want to answer that, Kevin?
Well,
Yeah.
oh, Kevin, you go ahead. You go.
Yeah, so people, there was the carpet cleaning thing had been a thing a long time ago, that there was some maybe association, but it hasn't panned out. It's not associated in bigger studies. There was a study that had raised that question, but it's not associated. Stagnant water, not specifically that we know of. There are some theories that there may be fungus in the air at certain times in certain places that trigger that immune response we were talking about. Generally, we think probably in many cases it's a virus, because like we're all exposed to viruses. But there's a chance that there's also things in the air, and there are some studies supporting that. There could be fungus in the air in certain, but these are like big, massive weather patterns. These aren't local events like where you're at the beach or something like that. These are like tropospheric weather patterns across the world. So kind of getting into the weeds of it, but not a trigger like that. No, it's nothing specific like that would have been being at a beach or obviously the carpet cleaning thing does not trigger it.
I would just say that beaches are specifically not a risky place. The papers that came out were more related to lakes or stagnant water rather than very active water with waves. So I don't think you need to feel guilty or worry about that. We are now at 45 minutes. So I'd like to conclude this and thank everybody for coming. As mentioned, we are happy to answer questions at any time that you have the need, and enjoy the rest of your day. Bye-bye.
Bye. Thank you.
Thank you.
Thank you.